community and not have them need to come into the clinics or hospitals, the better. This is also important, going back to the testing. It's important to understand that the decision to test is really a clinical judgment by the patient's provider based on their clinical symptoms and risk factors. While the University of Washington, our virology lab, can perform the test, the sample actually has to be collected by those outside clinicians and then sent to our lab for processing. And so I just wanted to clarify that because sometimes there's been a misunderstanding in terms of what we're able to do. What we don't want people to do is to just show up to be tested because they are concerned without first going through their clinician to see, do they have symptoms that are compatible and should they actually be evaluated. If we don't do that, we will overwhelm our clinics and overwhelm our emergency departments. Now, many of you saw some of the social distancing metrics that the governor and the local jurisdictions have implemented. It's critical that we do that at this stage of the outbreak to what we refer to as flattening the curve, meaning for our health systems to continue to function, to be able to provide the care not only for those patients with COVID-19, but for those patients who need other medical care. We have to decrease the volume of patients coming into our facilities and spread that over time. And so that's why those social distancing measures that the governor and others have implemented are so critical. And this is why we are really emphasizing the biggest thing that people, particularly with mild symptoms, can do is to stay at home. Don't go to work. And we're telling all of our employees the same thing. If you have symptoms, please stay at home. Check with your provider if you have questions, but we really need to keep our healthcare workers and our workforce healthy and safe while we continue to fight this pandemic. Now, another development that I want to share with you is that we have learned that we have 2 patients in our geropsychiatric unit on the UW Medical Center Northwest campus that have been diagnosed with COVID-19. And I'm going to turn it over to my colleague, Dr. Santiago Neme, to discuss the details of those 2 individuals and, most importantly, our response as we continue to ensure the safety for our patients as well as our healthcare workers. Santiago.
Thank you, Tim. So my name is Santiago Neme. Good afternoon. Like Tim, I'm an infectious disease doctor, and I'm the medical director for UWMC Northwest. Earlier today, we found out that 2 of our patients in the geropsych unit turned positive for COVID-19. These patients were quickly tested and put on precautions while their test was pending. Quite immediately, we convened a group to talk about the situation. Briefly, the geropsych unit is a unit that has 27 beds. All but 2 or 3 rooms are individual rooms. And again, 2 of 22 patients tested positive. Immediately after knowing that, that 2 of the patients tested positive, and also in understanding the environment of a geropsych unit where there's socialization, there's group activities, we immediately decided to start precautions for all 22 patients. Precautions meaning that we instituted our special droplet contact protocol for each room with specific techniques around donning and doffing protective personal equipment, also known as PPE. We also, as part of the strategy in trying to investigate this, the development of these 2 cases, the natural question is, could there be more patients affected by this? So by 1 p.m., we had tested all 22 patients, and their tests are now pending at our virology lab. We also discussed the case, these 2 cases with the staff, and immediately after we started conversations with the family members of those patients. And at this moment, the 2 patients who were positive were transitioned to the medical side to make sure that they're safe and away from the other patients. Those 2 patients that remain stable, in stable condition. And family members have been, again, communicated, and with full transparency, we discussed what the plan was, both for those 2 patients, but also for the rest of the patients. We typically do not test everyone, but in this situation, we needed to get more information and really jump on it quite rapidly to make sure that we understand. And luckily, fortunately, with the University of Washington testing, we could actually get that information. We're going to be able to get that information pretty quickly. The patients that we did test seemed pretty stable also. And there were no concerning signs or symptoms at the time. And the plan, again, is to reinforce hand hygiene practices, reinforce the use of protective personal equipment, also inform staff that this is a pandemic, and everyone's affected. As some of us have said in the past, viruses do not discriminate. They affect everyone. There are people in Italy struggling. There are people in France. There are people in New York, everywhere, really. So what we can do, I think, as a community, especially healthcare community, is to not panic and really get informed and know what our tools are to get better. So therefore, we provide frequent updates to the medical center, included at 3 p.m. today. We had a town hall because we want to really encourage distancing. This was done via an application where folks could call in remotely, and we had greater than 100 participants calling in, and some folks were live in person. But again, to gain transparency and to let staff know what we're doing. But in this, I feel, as Tim said, these situations are challenging, and no one's having fun, and this is affecting our lifestyle, the way our kids are not going to school, childcare, all these things that are happening, the ability to go on vacation and things like that. But I would say in terms of preparedness, I feel very confident in our efforts through UW Medicine, that the system has been organized for several weeks, and leaders leading this effort have been organized for years, including our colleagues at Harborview, with really special skills to handle these situations. So that's the summary, and we're happy to take questions.
The 2 patients, have they been in that unit a while, or did they come in with the infection with them?
Yeah, so some of the challenge with folks, so the unit has, I would say, approximately 2/3 of the unit is an involuntary admission. So there are patients who struggle manifesting symptoms, but there were no overt signs of respiratory infections in either patient. It is unclear whether they came with the infection. I suspect that they might have. Again, we at the Northwest campus, we serve a population that tends to be elderly, and not infrequently we have folks who live at skilled nursing facilities or long-term facilities. So we're doing part of that investigation to track that and also inform where they came from. But I would have to say that it's challenging in terms of the symptoms, and especially in the elderly, what we're seeing is that some folks are subclinical. And when you add the mental health issues and the inability to freely express symptoms really clearly, then it adds a complexity, an additional complexity.
I just want to build on something that Dr. Neme said. When you look worldwide around the severity of illness, and we're still learning about the range of disease, typically 80% of individuals will have mild disease, and they won't require any hospitalization or higher level of care. What we also have seen, though, that the individuals who are at greatest risk for more severe disease tend to be those individuals older, particularly over 60, but it continues to go up with older age, as well as those individuals who have underlying medical conditions. And unfortunately, what we've seen with our local outbreak, really in a very tragic way is what we've seen within our long-term care facilities, right? We have seen, unfortunately, those individuals who are older in age be really directly impacted by this virus. And I think this is one of the challenges as we look at the symptoms, that we know with most infections that individuals, as they get older in age and their immune system wanes, that they don't often present with the classic symptoms. And so while we often think of fever, cough, as some of the primary symptoms that people present, and in fact, if you look at some of the early cases, almost everyone had fever in those early cases. But as we learn more about the different patient populations affected by this infection, we are going to see that in some, and I think that's what we're learning here in our local experience, is that sometimes those individuals who are older in age don't manifest all those symptoms, which creates even more challenge to be able to identify those. But I think it's an important part that we as a medical community are all learning as we go through this together.
Are you guys able to provide any more information on the patients who tested positive, age, gender?
You know, not at this time. They're both in stable condition, but not at this time.
And what unit is it?
It's a geropsychiatric unit, which is the only geropsychiatric unit that we have within our community, but it is then does care for individuals who are older and potentially at increased risk should they get infected with this virus.
It shows older people with mental health issues?
Mental health issues.
And some are in there involuntarily?
2/3 are involuntary, yeah.
Are you going to be are there plans to test the healthcare workers that have been treating these patients?
Yeah, so for healthcare workers, we have a screening process, and you guys, as some of you have actually visited the clinic, where our policy or recommendation is that everyone with symptoms should get tested, and they call and they get tested quite rapidly. Now, for exposed professionals, we have a risk stratification as to what type of exposure. A close contact, like being within 6 feet of a patient and also for prolonged periods of time, increases the risk of infection, right? Because the length of exposure matters in terms of infection transmission. So we risk stratify providers, but the key message here is that the message to healthcare workers is that if they need to monitor symptoms twice a day. If they're asymptomatic, they may return to work. But the minute they get a symptom, they go off work and they get tested. That's our recommendation, which is in line with public health recommendations.
I also just want to build upon, again, what Dr. Neme was saying. Normally, we recommend not testing people who don't have symptoms. The reason we're doing this, particularly within this unit, is because of the identification of these 2 cases. And this is similar to what we would do if we happen to see an increase in influenza cases in a particular unit or norovirus in a particular unit, that we do additional monitoring and surveillance to look at those individuals who may have been exposed. But again, I want to emphasize for the community that we really discourage routine testing of people who do not have symptoms. It's really not indicated.
Where did these 2 patients come from before they entered this particular ward? Were they in nursing facilities or in a family home or homeless, or do you know?
One of the individuals came from another long-term care facility, and we're working with public health in terms of that evaluation.
Have there been other cases at that facility?
Yeah, I think it's too early to tell. We're just starting that process with public health.
Going back to testing for a bit, I do feel like as this virus continues to impact our city, there are more people raising questions about what testing looks like and the logistics of it all.
Mm-hmm.
I know you guys are not recommending that you go get tested if you don't have symptoms, but if a provider does decide to
Mm-hmm.
test a patient, what's that look like for them? How much are they looking at paying? What resources
Mm-hmm.
do they have to contact?
Mm-hmm. So the test itself, again, this is a respiratory virus. It's the same nasopharyngeal swab that we use to test for influenza or other respiratory viruses. So from a patient standpoint, when they're in their physician's office, as an example, The test is a swab that goes through into the back of the nasopharynx, and then that swab is sent to the lab, and it could be our lab or it could be the state lab, and then the lab does what's called a PCR test where they amplify the genetic material to see if the virus is present. And within our lab, the turnaround time is right around about 10 hours now. So if we get those samples in the morning, we typically have the results by the end of the day. So the testing from a patient standpoint, it's the same sort of collection of a sample as you would do with influenza or other respiratory viruses. Now you asked about the cost. The cost from the lab standpoint is, I believe, around $250, which is the same price if you look at other labs around the country who are able to perform this test. Now, our insurance commissioner in Washington State has been working with payers to be able to waive deductibles, waive co-fees, and what I really want to emphasize is that the ability to pay will never be a barrier for us in terms of being able to appropriately care for the patient, and if they need testing, we will get that testing done. And there is a lot of work to look about the overall funding of that, efforts just like the insurance commissioner did, but again, we don't want that cost to be a barrier. This is a public health crisis, and we and all of our partners within the community are responding and testing whenever it's indicated.
And we seem to be hearing so many different opinions about whether or not testing is actually readily available.
Mm-hmm. So I want to put this in context too. So when you have an outbreak like we're having within our community, testing is an important component, but it's not the only component. For an individual patient with mild disease, it's not necessarily going to help that individual patient other than they should be staying home. But they should stay home if they have influenza or any other respiratory illness as well. It does help from an overall surveillance of understanding, well, what is happening within our community in terms of transmission and how many cases. And so there's a surveillance aspect, particularly from a public health standpoint, that is of value. From a medical side, those patients who are admitted to the hospital with respiratory symptoms, we definitely want to test because we need to know how best to manage them and what sorts of precautions to use for them while they're receiving care, whether they have COVID-19 or if they end up having something else, if they require hospitalization. Public Health has also put out a prioritization list, and so while they say that testing can be available to anyone for whom their clinician feels within their medical judgment, it's indicated, they're also prioritizing groups. So they're prioritizing individuals who are over age 60, prioritizing individuals who have underlying medical conditions. And so all of that goes into the judgment of the clinician. So the availability is there. Our lab right now, as I mentioned, we can do roughly 2,000 tests a day. We haven't hit that capacity yet. We are